Welcome to my YouTube channel. Today we're going to talk about multiple gestation. Kindly subscribe. It will cost you nothing. Nothing, actually nothing. So let's begin. Multiple gestation is where there's a pregnancy with more than one fetuses. So they include twin pregnancy, which is the most common form of pregnancy, and three fetuses where we have triplets, four fetuses where we have quadruplets, five fetuses where we have quintuplets, and six fetuses where you have sextuplets. So twin gestation, which you said is the most common, there are two types of them. Like there is zygotic twins. There's zygotic twins where we have di means two, zygotic means a zygote. So a zygote forms when a sperm and an ovum fertilizes the egg. When a sperm fertilizes the egg, we form a zygote. So zygotic twins form when we have two sperms and we have two ovums. So the sperms fertilizes the respective ovums. So it is the most common one, that is 80%, and it results from fertilization of two ova, as I've said before. Monozygotic twins is where we have one ova, meaning one means one mean mono mean one. So meaning we have one ova and one sperm. After fertilization, we have monozygote, that is one zygote. This zygote, can separate or a cleavage can develop in when gestation continues. A cleavage can develop to separate the zygote. So it is 20% and result from fertilization of a single ovum. So pathophysiology, as we said, the zygotic twins are 80%, and they're also called fraternal binomial. They result from fertilization of two ova by two sperm during single ovulation cycle. As I've said before, the babies bear fraternity resemblance to each other, that of brothers and sisters from different births. So at the outcome of these babies, they have different personalities. Actually, they could have different sex, that is boy and girl. They don't resemble each other. They look like you and your sister who had left you 2 years or 3 years. So monozygotic twins, that is 20%. These are identical twins and they are uniovular twins, meaning one ovum. The twinning may occur at different periods, as I've said before, after fertilization. This is markedly influenced by the process of implantation and the formation of the fetal membrane. So types of monozygotic twins, we have four types of them. So the division occur between 1 to 3 days, that is 0 to 72 hours after fertilization. Prior to the modular stage, the resulting embryo will have two placentas and two chorions and two amnions. So we will call that diamniotic dichorionic, that is DDs, and the incidence of this is 30%. So when the division occurs for the fourth day, the fourth day to the eighth day, after the formation of the inner cell mass, when the chorion has already developed, then you will have diamniotic monochorionic, because already the chorion has already formed. The chorion later comes and form the placenta, meaning that these twins will share one placenta, however, have two different gestational sacs. So when the division occurs at the 8 days of fertilization, when the amniotic cavity has already formed, then we'll have monoamniotic monochorionic, that is MM, and it's rare, that is 1 to 2%. So the most common one, which can come actually in your MCQs, is the diamniotic monochorionic. So when the division occurs 2 weeks later after the development of the embryonic disc, you will resort to conjoined twins, which are also called semi-C twins. And it's rare because you can see it's less than 1%. So the types of fusion in terms of semi-C twins, you can have the thoracopagus, where you have the thorax fusing, pyopagus, where you have the posterior fusing, craniophagus, where you have the cranius, that is the head fusing, and istiopagus, is just like ischium, where you have the colon fusing. So this is just a repetition of what you have said. So we said after fertilization occurs, where the ovum and the egg, where the sperm fertilizes the ovum, we form a zygote, right? After forming a zygote, it undergoes mitotic characteristics. So it undergoes the mitotic process, forming a morula. So when cleavage occurs between day 1 and day 3, we form a dichorionic diamniotic, meaning two gestational sac and two different placentas. However, now later after the morula forms, we get the blastocyst, and the blastocyst we have the inner cell mass, and the inner cell mass, where do we have from the chorion? So that when the division occurs from 4 to 8 days, we'll have a monochorionic, meaning they share the same placenta, and we have a diamniotic, meaning they have two different gestational sacs. and you can see here, and we say this is the most common. So later, when you have implanted blastocyst, that is day 8 to day 13, you will have already, when the chorion and the amnion has already formed, you will have a monochorionic and a monoamniotic, where you have the same placenta, you have one placenta and you have one placenta and you have one amniotic sac. So later, when we already formed the embryonic disc, that is 2 weeks later, and cleavage occurs at this stage, you will have conjoined twins. And we say these conjoined twins could be divided, the joining could be in 4 areas, where we say cephalic, where we say caudal, that is esophagus, where we say posterior, and we say thoracovagus. So in terms of risk factors, it is highest in the blacks and lowest among Mongols, who are intermediate of Caucasians. So in terms of hereditary, it is female, like hereditary. So if your mother and you are a female, had twins, you have a higher risk of having twins to the maternal side. Advancing age of the mother, maximum being between the age of 30 and 35. Increased parity, especially from the fifth gravida onward. And iatrogenic, that is ovulation induction in assisted delivery. So in terms of uh, special physiological changes that occur in terms of twin or multiple gestation include increased weight gain, obvious, increased cardiac output, increased plasma, increased plasma volume by addition of 500. So in this case, we have increased plasma volume, but we don't have an corresponding increase in the cell red cell volume, resulting to hemodiffusion and anemia. So in these pregnancies, we always advise the women to take supplements of iron, among others. And also you monitor for anemia and its complication. There will also be increased alpha fetal protein. So in terms of diagnosis, obvious in history, you have to ask, did this person go for ovulation induction? Do they have twinning, especially on the maternal side? Do they have symptoms of exaggerated pregnancy, such as hyperemesis, weight gain, large abdomen, limb swelling? Do they have a history of hemorrhoids? Because hemorrhoids are predisposing factor of hemorrhoids is pregnancy, and obvious because this is pregnancy and it is multiple, it's kind of, the risk is kind of doubles. And excessive fetal movements. So in terms of examination, obviously we say this patient is predisposed to having anemia. So the patient may present in with pallor and elevated BP, because we said obviously the cardiac output will be increased, and lower limb swelling. So in terms of abdominal examination, the fetal height will be greater than the date, and you have multiple fetal parts or poles, and then we'll have multiple fetal height that is greater, like when you do fundal height, so the fundal height will be greater than the date. Then we'll have multiple fetal parts or poles, and then you have multiple fetal fundal heights. So when on examination, you're going to find like the fundal heights, and they'll be greater than 10 centimeters apart, or greater than 10 beats per minute in difference. So in terms of the investigation, obvious ultrasound is very important in terms of detecting multiple fetuses, in terms of detecting the placenta, and determining how many placentas do we have, what is the location of this placenta, among others. Also determining the amniotic sac, in terms of determining fetal growth and fetal well-being. Do we have restriction? Do we have twin to twin transfusion? In terms of determining the line, the presentation, and the fetal anomaly. In terms of biochemical, we have these three tests which will be doubled in terms of twin pregnancy. So we have maternal serum beta HCG, that is alpha fetal protein, and unconjugated estradiol will be approximately double that those of the singleton pregnancies. So in terms of differential diagnosis, because obvious after you have done your diagnosis, you'll have things running in your mind. So this could be a large fetus. That's maybe why you'll have like fundal height greater than the date. Maybe this will be wrong dates. Maybe this will polyarrhythmias. Maybe this could be the obesity of the mother, or maybe hydrocephalus, or maybe uterine or ovarian mass, such as fibroids. So in terms of the complication, we'll divide them very well in terms of the antenatal, intrapartum, and postpartum. So in terms of the antenatal that is during the gestational period, we'll have hyperemesis, we'll have anemia, as we said, obvious because of the hemodilution. We'll have preeclampsia, polyhydramnias, because already we have two number of fetuses which will have increased number of urine output, and we also have increased risk of antepartum hemorrhage and preterm labor. Mechanical factors which I've said before, which include hemorrhoids and respiratory distress. Because of these big babies compressing the diaphragm, the patient could have respiratory distress. In terms of the interpartum, that is during labor, you'll have risk, early risk of rupture of membranes, which could be associated with or without cord prolapse. In addition to prolonged labor, PPH, that is PPH is postpartum hemorrhage and antepartum hemorrhage and operative delivery. In terms of postpartum, you have increased PPH, lactational failure, and increased risk of puerperal sepsis. So in terms of the fetal, what are the complications in terms of the fetal? You can have abortion, you can have prematurity, obviously, because most of these fetal, especially monochorionic, monoamniotic, you will deliver them earlier, which will result to prematurity. You can have discordant growth, that is twin to twin transfusion, which we'll talk about it later, placenta insufficiency, intrauterine growth restriction, or from structural abnormalities occurring in one feature. In terms of intrauterine growth, death can occur if we have cord compression, if you have competition for nourishment, or congenital anomaly. Asphyxia and stillbirth can occur when we have, for example, preeclampsia, malpresentation, placenta abruption, and increased operative interferences. Fetal normally, they are at a risk of 2 to 7 in terms of incidence, where you can have anencephaly, hydrocephalus, microencephaly, cardiac abnormalities, or Down's syndrome. So in terms of management, we have grouped them into, now we have antenatal. In terms of antenatal, we'll start obviously with diet. So you tell the patient to increase their dietary supplementation and increase calorie intake. If you have had like women say that they are feeding for 2, now this woman will be feeding for 3 or maybe 4. So in addition to that, you tell the woman to increase stress from that trimester. This is to reduce the risk of preterm labor. In addition to that, you ask the patient to supplement iron, calcium, and folic acid, and also you look for complications such as anemia, preeclampsia. You do fetal surveillance, and also assess for malpresentation. This visit, that is a clinic visit, should be frequently, at least once a month, and the fetal scan should be done every 3 to 5 weeks. Advisable, when a woman comes to your clinic, make sure, if especially this woman is high risk, make sure you do an ultrasound scan. So during the intrapartum period, during the delivery period, so we have we have 3 modes of delivery, where we have vaginal delivery, where we have cesarean delivery, and where we have assisted delivery. However, today we're going to talk about the two. There's the vaginal delivery and the cesarean delivery. I hope we are good at that. So we said we have 2 types of twins, where we have the fraternal twins and we have the monozygotic twins, the identical twins. So in terms of the fraternal twins, it's simple. So if the vaginal delivery can occur when both twins are at cephalic presentation or vertex presentation, or at least the first twin is at vertex presentation. That is for the fraternal twin. I hope you are okay. Now on the monozygotic twin, if it is die, then we have a leavage, because these twins have their different amniotic sac and different placenta, meaning we can do vaginal delivery. So, and we can only do vaginal delivery when both twins are at vertex presentation, or at least the first one is at vertex presentation. We're going to see the indications or the role of CS in the next slides. So during the first stage of labor, so it just plays out like singleton. So we will do the various steps of the first stage of labor and the second stage of labor. So in addition to that, we'll also require like skilled individuals, that is obstetrician, anesthetist, and neonatology, because already we are having multiple gestations. So one could be overwhelmed in case the two need attention. Patients should be in bed rest to prevent early rupture of membranes. In addition to that, you do fetal monitoring. So RVE should be done as soon as rupture of membrane occurs to exclude risk of cord prolapse. So cord prolapse is a complication of multiple gestation. So when the mother has ruptured membrane, that is the first stage of labor, then you should do RVE to exclude cord prolapse. Kindly note, now when you go to the second stage of labor, that is the delivery of the baby, and you have already delivered the first baby. After you have delivered the first baby, you should not give oxytocin after the delivery of the first baby. This is because we predispose the second baby to asphyxia because of the contraction of the uterine arteries. Later, after delivery of the first baby, you've already delivered the first baby, you've said not give oxytocin, you are starting the lie of the second baby. So if the lie is longitudinal, then you rupture membranes and wait for spontaneous delivery. However, if the lie is oblique, then you go for cesarean section. That is obvious and absolute indication of cesarean section. Later, you continue simultaneously continue do fetal monitoring, and if there's no contraction within 10 minutes, then you put this patient on oxytocin drip to augment labor, and then you deliver the second baby. Then, in case we have a retained subsequent twin that is greater than 30 minutes after delivery of the first twin, you consider cesarean section. So after now you have delivered the second twin, you palpate the uterus and ensure that there is no baby before giving oxytocin. Then later you conduct the active management of that stage of labor, and you examine the placenta for consanguinity and zygosinity. Continue in addition now, that is the active management of that stage of labor involves giving of oxytocin to avoid PPH, that is postpartum hemorrhage. So you continue giving the IV oxytocin for 1 hour after the delivery of the placenta. So the role of cesarean section, now here we are going to divide them into two. That is the obstetric indication. So for example, this pregnancy, the patient comes in with malpresentation, comes in with malposition. These are obstetric complication indications. Or we have a complication such as preeclampsia. So twin related is, we already discussed this, when both fetuses or even the first fetus is non-cephalic, or for example that is breech or transverse presentation. So we said vaginal delivery can be done when both fetus are vertex, or at least the first one is at vertex presentation. I hope you are all on the same page. So twin complication, we have intrauterine growth restrictions. So when you have these twin complications, it's also an indication for cesarean section. That is intrauterine growth restriction and conjoined twins. In addition to that, monoamniotic twins, twins that share the same amniotic sac. And next is monochorionic twins, monochorionic twins with twin to twin transfusion syndrome. So in addition to that, collision of both twins at the brim, preventing engagement of the head of either of the head. So we already said you can deliver these twins when they are at vertex presentation. Now assume that both these are twins and both at vertex or at cephalic, and the heads come down. Both of the heads come down in the woman's brain, meaning that we have limited space. So that is absolutely indication of cesarean section, because neither of the head can go to delivery of mono to mono should occur earlier compared to this. Twin to twin transfusion syndrome. This is a serious complication that affects 10 to 15% of the monochorionic diamniotic twins. Meaning these twins have they share one placenta, that's the keyword, they share one placenta. However, they have two gestational sacs, meaning they have two amniotic sacs. So it arises due to unbalanced blood flow between the twins through the placental vascular anastomosis, because they share one placenta, leading to donor and recipient relationship. So the donor twin, that is the person giving more of the blood, will have hypovolemia, oligohydramnias, because if they don't have now the blood, what like urine are they going to urinate? So like, they'll have oligohydramnias, intrusion, growth restriction, while the recipient, the one receiving, will have hypervolemia, polyhydramnias, cardiomegaly, and potential fetal hydrops. So in terms of diagnosis, it is primarily based on ultrasound findings, where you'll find the presence of oligohydramnias in the donor's twin. That is the maximum pocket, that is maximum vertical pocket of less than 2 centimeters, while polyhydramnia on the recipient twin, that is the maximum vertical pocket of greater than 8 centimeters. And then we have a staging system, that is the Quintero staging system, which is commonly used, and you classify from stage 1, that is mild, to stage 4 based on the ultrasound findings and the fetal Doppler parameters. So this is just a summary, a very good summary of mechanism and the complications of twins. So we're just going to go through it in a very simplified manner. If you have reached here, kindly subscribe. So risk factors, as we mentioned before: multiple embryo transfer, that is IVF; ovulation induction, as we say, that is hyperovulation and fertility medication; increased follicle stimulating medication, hormone, that is, including age 35 and family history. This allows for multiple follicles to mature. And then now you'll have two ova. This is for zygotic twins, sorry, where you have two ova ovulated, and each ova will be separated by a separate sperm. And then the two embryos will develop and implant separated into the endometrium, and they develop their own placenta and their own amniotic sac. The dizygotic twins, that is the dichorionic diamniotic by default. So where you have a single ovum, which will lead to ovum fertilized by a single sperm, and then a single zygote develops into a single embryo, but because of unknown, the cells split in the embryo and separate from one another, forming two embryos. So when it is split from day 0 to 3, the cells are undifferentiated at this stage, and it allows for the embryo to develop its own sac and its own placenta, meaning you'll have two placenta, that is the chorionic, and two amniotic sacs, that is diamniotic, and this will be monozygotic twins. So the next one is where the embryo splits at day 4 and day 8 after the trophoblastic cells, that is the outer layer of the trophoblast, have already invaded the endometrium and formed part of the placenta. So the embryo forms its own amniotic sac, and both leads to one placenta. So here you'll have one placenta and two amniotic sacs. Don't forget, we are still on the monozygotic twins. So when the split occurs between day 9 and day 12, where both the placenta and the amniotic sac development has already started, this will allow you to have one chorion and one amnion. So we will have monochorionic, monoamniotic. So I hope we are all together. So just as a question that I want to ask you, if you can remember what we said, which is the most common type of monozygotic twin where we have twin to twin transfusion, and why? It is monochorionic diamniotic because they share one placenta, and this occurs due to the intraplacental vascular connection that leads to an even distribution of nutrients and blood flow, leading to twin twin transfusion syndrome. So in terms of the mono, meaning they have the same placenta and they have the same gestational sac, meaning these children will be revolving around the same sac. Maybe let's say they are playing, they could end up hurting one another. That is the cord entanglement. So the umbilical cord could become entangled within the shared amniotic sac, leading to cord entanglement. So all other complication here are what just we talked about: over distension of the uterus, which will lead to weakened uterine muscles, leading to atony. So what are the T's? What are the T's that causes PPH? We say TOD, trauma, and go find the rest, the last two. That is postpartum hemorrhage. So large placental mass without increase in placental blood flow will lead to placental hypoperfusion and other complex mechanisms which will predispose this patient to having gestational hypertension and preeclampsia. Increased plasma volume, as we said before, leading and not have and diluting red blood cells, because the red blood cells do not increase. You'll have and plus increased fetal iron consumption from the mother's source. You will predispose the patient from having anemia, that is the fetus, and also the mother. Increased beta HCG because of a known mechanism will predispose the patient from to having hyperemesis gravidarum. Uterine crowding, which will lead to increased fetal malpresentation, which will lead you to having operative delivery, that is CS. Increased uterine crowding, and which will lead to small space into the uterus for continued growth, will lead these children to have preterm labor and also intrauterine growth restriction. Insufficient maternal nutrition and supplies, for example, the folic acid, will predispose these children to having congenital anomaly. In addition to that, when you have abnormal vascular connection, in addition to the insufficiency of the maternal supplies, can lead to death. Thank you. Make sure you subscribe.